Here's our quick roadmap. We'll hit the French classification, initial and definitive management, a key clinical pearl, classic exam traps, and then wrap it all up with a quick recall challenge. All right, part 1, the French classification. So the core concept here is that this entire system relies purely on how these two parallel tubes, the esophagus and the trachea, connect, or, fail to connect. Normally, they develop as totally separate structures, but here, that separation goes completely awry. This classification simply gives us a universal language to describe the exact structural defect we're dealing with. This breakdown illustrates the strict categories, types A through E, that you've absolutely got to commit to memory. Type A is pure esophageal atresia, with no fistula at all, just blind pouches. Type B, that's atresia with a proximal fistula, so the upper pouch connects right to the airway. Then there's type C, featuring atresia with a distal fistula. Type D is double trouble, atresia with both proximal and distal fistulas. And finally, type E. This is an isolated fistula without any atresia, often called an H-type because the intact tubes literally form the uprights of an H, with the fistula acting as the crossbar. Now, out of all those letters, if you only remember one single thing from this section, lock this in. Type C is by far the most common variant you're going to encounter. That's an esophageal atresia coupled with a distal fistula. When you hear a clinical vignette about this condition, your brain needs to immediately default to type C until proven otherwise. Moving right along to section 2, initial and definitive management. If you suspect this condition in a newborn, here are your immediate chronological steps to stabilize them. First, strictly nil by mouth. Feeding these infants is incredibly dangerous. Second, you have got to start continuous upper pouch suction. Because they have a blind-ending upper esophagus, saliva just pools up there and will spill straight over into the lungs if you don't actively clear it out. And third, start those IV fluids to maintain hydration, since obviously enteral feeding is totally off the table. Our initial workup is really designed to safely evaluate the anatomy while totally preventing aspiration. We also need to hunt for associated anomalies, because honestly, these defects rarely happen in a vacuum. A crucial step here is getting a chest and abdominal radiograph, while carefully passing a radiopaque tube. This is going to show us exactly where the anatomy hits a dead end. Once the baby is stabilized and worked up, we look toward the cure. The definitive treatment is surgical division of that fistula to finally separate the respiratory and GI tracts. We follow that up with a primary esophageal anastomosis, meaning, if anatomically possible, we stitch the two ends of the esophagus together to restore a normal, continuous digestive tract. Keep in mind, the specific anatomy absolutely dictates your timeline. For a most common type C, the surgeon divides that distal fistula and repairs the esophagus. But sometimes the gap between the upper and lower pouches is just way too wide to pull together right away. We call these long gap atresias, and they might force you into a staged or delayed reconstruction, depending entirely on the infant's condition. Let's hit section 3, a key clinical pearl. Check out the mechanics of type C. Just think about the plumbing for a second. The distal esophageal segment communicates directly with the trachea. So every single time the infant takes a breath, cries, or gets positive pressure ventilation, air gets pumped straight from the airway down that fistula and right into the stomach. And this anatomical shortcut directly translates to what you'll see at the bedside. Because air is literally filling up the stomach, you get profound abdominal distension. That distension pushes up on the diaphragm, restricting the lungs and causing severe respiratory distress. Plus, it creates a massive aspiration risk, not just from saliva above, but from acidic gastric juice washing back up that distal fistula and straight into the lungs. It's a perfect storm. Okay, section 4, classic exam traps. Examiners love to trick you here, so don't fall for it. Look at the stark contrast. On the left, type A. That's pure esophageal atresia with zero fistula. It is strictly a digestive tract interruption. Now on the right, type E, the H-type fistula. Here there is no esophageal atresia. The esophagus is totally open, but there's this sneaky little bridge over to the trachea. The clinical presentations are completely different, so keep them firmly separated in your head. Similarly, when you're looking at x-rays on exam day, you've got to be a detective. If you see a radio-opaque tube just coiling in the upper chest, that's your classic dead giveaway for esophageal atresia. The tube hit the blind pouch. On the flip side, if you spot air in the stomach or bowel gas in a newborn who hasn't been fed yet, that heavily points to a distal fistula leaking airway gas down into the gut.
All right, Section 5, Quick Recall Challenge.
Let's see if this stuck. A newborn presents with respiratory distress and excessive drooling. You figure out the infant has esophageal atresia, and imaging shows the distal esophageal segment communicates with the trachea. What type is this according to the French classification? Take a second, picture the anatomy we just mapped out. Got it?
It's type C, the absolute most testable, most common concept in this whole framework. So you now know the anatomy, the initial steps to keep the baby safe, the surgical goals, and how to spot those classic radiologic clues. As we wrap up this explainer, I want to leave you with this. Once the surgeon actually manages to reconnect this tiny anatomy, what kind of lifelong complications might this child face as that newly repaired esophagus grows? Think on that, keep your visual memory strong, and you are going to completely ace this on your